They received an award of Pharma Excellence for COVID drugs. Today's webinar, Oseltamivir in Flu Management, we have Dr. Pramod sir as our moderator and Dr. Ketan Shah and Dr. Ravindra Chopra as our speakers. Welcome, doctors, to this webinar. Dr. Pramod sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAV CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Dr. Ketan Shah is MDDCH, President Surat Pediatric Association 2003, National Trainer ATM PSPP ASK, IIP CPIDC, How Do I Investigate, Rational Antibiotic Practice, National TB Module, Rapid Module, etc. National Secretary, Pediatric Rheumatology Chapter 2005 and 6, Organizing Chairperson, National Rheumatology Meet 2006, EC Member, Gujarat Pediatric Association 2014-2019, EC Member, ID Chapter 2013. Dr. Ravindra Chopra is MBBS MD, Chief Pediatrician and Director, Muskan Children's Hospital, Surat. With this brief introduction, I hand over the session to Dr. Pramod Jog. Over to you, sir, and I'll stop sharing.
Thank you, Dr. Prashant. And today we are going to discuss about influenza and the role of oseltamivir in the management of influenza. And it's a very important topic because these days so many viral respiratory infections are coming in the OPD that we have respiratory syncytial virus and influenza virus. And many times it becomes very difficult to identify what is the type of virus which is affecting the child. Of course, some of these viruses are producing mild presentation as usual viral infections with rhinovirus, etc. But sometimes these viral infections are taking a serious turn. And recently I saw one child who had influenza and in addition had dengue fever. Now, we all know that both these viruses attack children in the monsoon. And the confusion was because, the WBC count and the platelet count both were on the lower side. So, while we were treating the child with oseltamivir to begin with, the child would not improve. And day 4 and 5, the child started worsening. At that time, we investigated the child for dengue and it also turned out to be positive. Of course, the child was managed successfully by our team and everything went on well. So there are quite a few co-infections going on along with influenza, and some of my colleagues and even in my setup, influenza with RSV also has been seen. So it's very important that we are aware of all these monsoon illnesses and how co-infection creates a problem. As regards influenza, we are all aware that the virus has rather come into picture, particularly in prominence after the 2009 H1N1 pandemic. And then everybody is aware of so many precautionary measures related to influenza. We are also aware that there have been quite a few noted pandemics right from 1919, which was actually erroneously called as Spanish flu because it had affected almost 1/3 of the global population. And then there were pandemics in 1957, 1968, and 2009. So influenza produces pandemics, and every year the presentation of influenza, though clinically remains same, the type of the virus, the structure of the virus shows some variations. So it is important that we know a lot about this virus, and oseltamivir is one of the important molecules in the early management of influenza, and it has a very good efficacy as regards the control of the spread of the disease to serious infection and also hospitalization and mortality. So we will discuss this particular topic threadbare today, and I am glad to have Dr. Ketan Shah and Dr. Ravindra Chopra to discuss about influenza and oseltamivir. And I hand over the session. In the initial part, Dr. Ketan and Dr. Ravindra will discuss about the virus, about the medicine, and they will also highlight a few cases. And at the latter part, we will discuss certain important cases which have produced some puzzling, thought in the mind, along with some common questions. So it's over to you, Dr. Ketan, for further proceeding. Thank you.
Thank you, sir. Thank you, Dr. Prashant, for smooth and very nice elaboration of the topic. And to Dr. Jog, sir, always very nice elaboration of the topic, very good initial bowling, which is always encouraging to the people like me and Dr. Ravi. Dr. Ravi is with me. He's a very good pediatrician and very nice academician. So we'll start a discussion on influenza and oseltamivir. The main content of the talk would be healthcare challenges in monsoon and their diagnosis, influenza, or classically called as a flu, and its complications, clinical evidence of oseltamivir, its utility, its uses, and its effect on suspected flu disease, and the guidelines recommendation for empirical use of oseltamivir. These are the four main content of the talk. Usually in monsoon, we get the respiratory illness very commonly. We label them as an influenza-like illness or called as an ILI, H1N1, which is very common, severe acute respiratory illness, and COVID-19. Nowadays also, we do get scattered cases of COVID-19, but the major chunk is flu-like illness and especially H1N1 also. Do we have any evidence that flu exists in India? In which season it comes? And what is the correct time to vaccinate? Let us look at the data. This graph is from the Purple Book of Indian Academy of Pediatrics. And as a pediatrician, we all know that the Purple Book is a Gita for us so far so infectious disease and vaccination is concerned. This is from the page number 324. These indicate the month-wise trend of cases of influenza reported in India from 2014 to 2019. As shown in the graph, the peak is between January to April and again into July and October. So in India, we get two peaks. One is in winter and another in the monsoon. This is the global burden of disease statistics from 2017. Number of influenza-like illness hospitalization was 5,88,000 and the death reported were 26,000. So globally also, the disease burden is very high. This is a year-wise distribution of cases from 2017 to 2022 in India. In 2017, 38,000 cases and 2,270 deaths. And in 2022, 12,000 reported cases with 399 deaths up to November 22. So Indian data says that 5 to 10% of all ARI are due to influenza. 10 out of 100 children per year, they suffer from influenza. There are various studies from North India indicate that 178 to 180 children per 1,000 children per year, they do suffer from influenza-like illness. Influenza-associated acute respiratory infections are 33 to 44 per 1,000 children per year. And in 2009 pandemic, almost 22.8% cases were positive in pediatric population. In 2015 up to March, more than 30,000 positive cases and 1,809 death has been reported. So Indian data strongly favors that influenza does occur. It is a seasonal variability. In northern India, the peak is between January to March. Central India, it is July to September. Southern India, it is September to November. So winter and monsoon is the peak season, and pattern of circulating strain also varies from each year. Vaccination is strongly recommended looking to the scenario of influenza in pediatric population. This is again a graphical representation of influenza in India. as shown that the death due to influenza infection were 1218 in 2019 and number of reported cases in 2019 were more than 28,000. So there was a one very concrete study which has been done in the Chennai. Dr. Ravi, can you highlight on this study? Over to you.
Thank you, Dr. Ketan, and you have greatly summarized the influenza incidence and the disease as such, the disease burden in our country. So this study was one of the milestone study because people used to think that influenza does not exist in India and there is no influenza season till far. And this was an eye-opener study. And this study was done conducted in the Department of Virology at King's Institute of Preventive Medicine and Research. And in this, around 36,600 specimens were subjected for influenza viral analysis over the period of 7 years. So this was a prospective kind of study, and for analyzing the influenza virus in suspected ARI cases. And this study depicted that the positivity started with the onset of monsoon and peaks during the post-monsoon months. As Dr. Ketan has already highlighted in what we have in our purple book, there are two peaks, and this is one of the landmark studies which define these peaks.
Thank you, Dr. Ravi. Now let us look at the influenza virus or a flu virus. It is one of the most common infectious disease caused by influenza virus. It is a highly contagious airborne disease that occurs in seasonal epidemics and manifests as an acute febrile illness. It can cause mild to severe illness. Serious outcome of flu infection can result in hospitalization or even in death to the children and even in the immunocompromised patient. There are three types of influenza virus. Dr. Ravi, can you take this part? Over to you.
Yes. So as we all know that influenza is a RNA virus and highly infectious virus. And this virus is classified according to its nucleoprotein, which is a part of all the viruses, and M capsid, which is part of influenza A virus. So influenza A will further be classified. So depending on these, like influenza A virus, which is the most common virus and causes frequent epidemics and major health burden to our day-to-day practice. And this virus has minor antigenic variation, which we'll talk a little later. Because of these minor antigenic variation, it causes seasonal variation. And we have a new influenza virus almost every year and maybe in every season. And sometimes there are like significant viral changes which leads to periodic pandemics. Influenza B virus is mostly limited to humans only, and it causes local epidemics which are limited to a particular geographical area. Influenza C virus is a virus which is a minor component and it infects human as well as the swine. So influenza C virus generally causes a very mild respiratory illness and are not thought to cause any epidemics and not generally considered as a major health hazard for the human beings. So why this kind of antigenic variation comes to this virus? And there is a different vaccine for every season is because of drift and shift in the virus. So drift means a minor reassortment or minor antigenic mutation in the virus, which makes the human being more vulnerable to fool our immunity and get infected. Whereas the shift is a major reassortment, or probably it is entirely a new antigenic virus, which completely decepts our immunity and causes a huge number of cases in a local community or nationwide, maybe worldwide also. So this is cause of major pandemic, which we, as Dr. Chok has already narrated, that we had a Spanish flu, Asian flu, and we had lately in 2009 we had a swine flu. So this is because of the shift mechanism of the virus. Currently, we have generally H1N1, which is a major chunk, and H3N2 as a circulating virus in our day-to-day clinical practice.
Thank you, Dr. Ravi. This is about the microbiology of the influenza virus. The concept of drift and shift, we all should know. Therefore, every year WHO recommend that the vaccine should have these type of strain, and they do predict that A, B, or type of A, subtype of A would circulate these year. So this is how the influenza creates a trouble to us. Transmission of flu virus, it is very highly contagious. It spreads at about 6 feet distance also. Flu virus are spread mainly by droplet. If you cough, if you sneeze, or if you talk, you can spread the disease. Droplets can land in the mouth or nose of the people who are nearby, or possibly be inhaled into the lungs. People should stay away from the affected person and stay home if sick. It is also important to wash hands often with soap and water. So hand hygiene is very important, which we followed in COVID also. Most healthy adults may be able to infect other people, beginning 1 day before symptoms develop and up to 5 to 7 days after becoming sick. And even children can pass the virus for longer than 7 days. So this was how does the influenza spread. And when you get the respiratory illness, we have some differential diagnosis on clinical ground, although not very easy to find it out, but there are few peculiar things where you can put your finger that this patient may have an H1N1, SARI, or COVID-19. I would request Dr. Ravi to highlight the differential or symptomatological differentiation of these various diseases. Over to you, Dr. Ravi.
Yeah, so as Dr. Ketan has already narrated that it is very, very difficult to differentiate. So a broader terminology was given as ILI, so called as influenza-like illness. Any febrile illness which has a fever more than 100.5 with sore throat and respiratory symptom is generally classified as ILI. So this is a broader category in which comes the other subtypes. So all ILIs generally have fever, myalgia, cough, lack of energy, sore throat. This is the prototype of ILI. So there are few differentiating features between H1N1 SARI and COVID-19. That respiratory distress or breathlessness is a major component of H1N1 SARI and COVID-19 both. But the systemic symptoms like headache is more profound in H1N1. Weakness and lethargy, they are more profound in H1N1 as well as COVID. And COVID also has a very peculiar thing that it has a symptomatology of loss of smell and loss of taste. Though it can happen in other respiratory illnesses also, other kind of flu and other illnesses, but it is quite peculiar of COVID. And other systemic involvement like diarrhea and GI involvement is more common in COVID. So that's how we can, like, decide what investigation and what kind of treatment to be instituted at the time of presentation. But the actual differentiation can only be done with progression of the disease, follow-up, and diagnostic test.
Thank you, Dr. Ravi. Very nicely elaborated. When you are sitting in your chamber with stethoscope and torch, it is difficult to differentiate which etiology is there. But however, loss of smell and loss of taste would definitely give a clue towards COVID-19. Yesterday only, I had one adolescent child, 18 years, female, came with a history of fever, cough, cold. And specifically, she mentioned that, sir, there is no taste in my mouth. There is no smell. I'm not able to perceive the smell of the surroundings. And taste in Surat, we all know that Surti Khaman, Surti Fafda, and Surti Gari, which is the season of today is a Chandi Padvo, and that is the season. And she could tell me कि सर आज मैं घारी का टेस्ट नहीं कर सकती हूँ because I'm not getting the test. So these are likely to be a COVID or sometimes influenza like illness. She had a severe prostration. She is in the hospital, although parents did not allow us to test what organism it is. So how to diagnose it? Before that, let us look at the some warning signs of flu as taught us in the PALS course. A, B, C, airway, breathing, circulation. If anything is compromised with some CNS sign symptoms, these are the warning signs. Any child who is breathing fast, who is not able to breastfeed, who is not able to drink the water, who is not able to go to the bed, getting irritability, dizziness, syncopal attacks, and cyanosis with tachycardia. These all are warning signs of any of the respiratory illness. We call it as an impending respiratory failure or acute respiratory failure. Even in adults, we get difficulty in breathing, breathlessness, chest pain, sudden dizziness, confusion, persistent vomiting, weakness, low blood pressure. These all are warning signs of any of the disease, but especially in the flu season, this could be a flu with warning signs. So once you suspected influenza-like illness, which could be H1N1, could be COVID, or could be some other virus, how do we proceed with diagnosis? Let Dr. Ravi to inform us. Dr. Ravi, what are the diagnostic modalities available for influenza disease? Over to you.
So during monsoon season, we have many ILI-like or viral illnesses we sometimes confuse. So with the routine investigation like hemogram, etc., they may be unremarkable, but sometimes they may indicate illnesses like dengue. So we have to rule out them first, and then specifically for influenza, we can test them for either a rapid antigen test, which is nowadays not commercially available readily, and it is not standardized. The mainstay test which we do is a PCR test, either typable or non-typable PCR. So typable test is the preferred one, WHO standardized test, which will be in the form of multiplex PCR. Non-typable will be in the form of flu panel test, which also tests around about COVID-19 and influenza A, B, and RSV also. And for practical research purposes or for virology lab, there can be a use of viral culture to subtype the virus and genetically analyze the virus. And rarely we do use a rising antibody titer as a diagnostic test for COVID. As far as complications of flu, if you talk complaint, Dr. Ketan has already elaborated some of the symptoms during his initial slides. But complication can be respiratory or non-respiratory. So in children, we know respiratory complication can be in the form of pneumonia, ARDS, then adjacent respiratory tract like otitis media, croup, and bronchitis, bronchiolitis. These can be respiratory complication, and non-respiratory, the most common can be the cardiac, like myocarditis, then muscle involvement, rhabdomyolysis, CNS involvement, uncommon, but sometimes encephalitis can be one of the feature. I haven't yet seen such cases, but it is mentioned in the literature. And one very dreaded complication which we used to see previously was Ray's syndrome. But with awareness and avoiding use of aspirin in flu-like illnesses, probably these cases are less and less in number. In adults, along with these complications, they have an exacerbation of the underlying diseases like a patient with COPD, chronic heart disease, renal failure, or any other gastrointestinal or other tract illnesses. There can be sudden decompensation and the patient may land up in intensive care unit. Dr. Ketan.
Thank you, Dr. Ravi. You nicely elaborated the complications of influenza. Parainfluenza does exist with influenza, and sometimes we get viral myositis in recovery stage. So that is also one common complication. Now, let us look at the management of influenza. We suspected influenza-like illness. We can do the diagnostic test. We watch for the complications. But as patient has came into the OPD, where should we use the Oseltamivir? The primary treatment of influenza includes bed rest, increased fluid consumption, cough suppressant, antipyretic like paracetamol, and very rarely NSAID drugs for fever and myalgia. Most patients with influenza, they recover in 3 days to 4 days. However, malaise may persist for weeks. Like patient would come and tell us कि सर अभी भी बहुत weakness लगती है, कुछ tonic लिख दो, कुछ ORS ज्यादा पिए, क्या करे, कौन सा खाना खाए जिससे हमारी weakness चली जाए. So that is basically a malaise which may persist for 1 to 2 weeks. Severe cases may require IV fluid and other supportive measures. We usually divide influenza-like illness in category A, B, and C. Category is a walk-in patient, low-grade fever, running nose, eye discharge, throat congestion, maybe a fever of 101 and 2, but otherwise he is comfortable. Category B is in addition to a weakness, vomiting, sick-looking child, probably he needs observation, monitoring, and follow-up. And category C, definitely having a systemic involvement, mainly a respiratory, with sometimes other system involvement, then it becomes a category C. So depending upon that, we decide the line of management. When we decide for antiviral drugs, we have a two category, neuraminidase inhibitors and adamantines. Adamantines are M2 ion channel blockers. Some pharmac about neuraminidase, it blocks the viral neuraminidase enzyme, which is critical in releasing virons from the infected host cells. These drugs are active against influenza A and B, and the prototype and well studied is Oseltamivir. Zenamivir is the another drug. However, it is not well studied and not approved by authorities. Adamantines, they interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. It is active only against influenza A virus, and the drugs listed are amanitin and ranitidine. So out of these two class, neuraminidase inhibitor is very important. And oseltamivir, which is a potent and selective inhibitor of these enzymes of the influenza virus A and B, it is a prodrug which is converted to the active form oseltamivir carboxylate in the liver. It inhibits influenza virus replication and its pathogenicity. It prevents further spread of infection, and it is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1, and H9N2 strains also. This is a pictorial presentation. How does the drug act? The upper part shows a normal pathophysiology. Viron is there. There is a neuraminidase inhibitor enzyme. Neuraminidase enzyme is there. It forms a new virus, and there is a release of new viron, and viral multiplication goes on. The lower part shows that when you use a neuraminidase inhibitor, this enzyme is not capable of forming new virus. So the viral multiplication is halted and the spread of the disease or viremia is very well controlled. So it was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. It is an FDA, CDC, and American Academy of Pediatrics approval. The dosage has been narrated here. The solution is available in the form of 12 milligram per ml. The dose recommendation is for 5 days. It is available in the capsule form also. It can be given in the form of a treatment or in the prophylaxis mode. Prophylaxis is for 10 days. The dose is depicted in the table. If adult, it is 75 milligram 2 times a day. Less than 15 kg, 60 milligram per day. So it comes to 2.5 ml BD, and the prophylaxis is 30 milligram once daily. For 15 to 23 kg, it is a 90 milligram per day or 3.75 ml 2 times a day. 23 to 40 kg, it is 5 ml BD, and more than 40 kg, it is 6.25 ml BD. If child is 2 weeks to less than 1 year of age, the dose recommendation is 3 milligram per kg twice daily. So around 0.25 ml per kg is the dose. It is safe in this age group also. Now let us look at the case scenario, which are the real case scenario. These the cases has been reported by Dr. Ravi. So I hand over to Dr. Ravi to describe the cases. Over to you, Dr. Ravi.
Yeah, so these cases are my real scenario cases, and I'm sure that we all might have encountered such kind of cases in our practice. And one of these is Ishani, 6.5 year female child. She was a resident of Vesu, Surat. The child was immunized for routine childhood illnesses, but skipping the influenza annual vaccination. The child presented with high grade fever, 103 to 104 degree Fahrenheit, with cough and cold for last 2 days and pain in the throat for 1 day. Before landing into hospital, child actually came to hospital with breathlessness, which according to her was increasing for the past few hours. There was no significant past history and no family members were suffering from any kind of disease at that moment. Though, according to her mother, that many of the classmates were suffering from fever and cold. Child was well nourished and febrile with a axillary oral temperature of 104 degree Fahrenheit, mild tachypnea with respiratory rate 42 per minute, and mild subcostal retractions. Child was tachycardic with a heart rate of 150 per minute and blood pressure of 90/60. Her room air saturation was 93 to 94%. And on throat examination, it was severely congested with significant watery nasal discharge. And child had mild respiratory distress and chest showed bilateral crepes, mainly on the bases. Rest, all of the systemic examination were normal. So we started stabilizing the child and simultaneously investigated her. CBC had shown a normal hemogram with hemoglobin of 11.9 and total WBC count of 5,800 with mainly polymorphic, normal CRP, and X-ray, which was done a little later after stabilization, showed bilateral significant perihilar opacities and prominent bronchovascular markings. So considering above finding seasonality and epidemiology, the child, we sent a respiratory multiplex PCR for the child, and which later came positive for H1N1. So during the course of hospital stay, the child was started on supportive treatment in the form of IV fluid, oxygen inhalation with nasal cannula at the rate of 3 to 4 liters, and oral oseltamivir was added after the influenza report. Child continued to have high-grade fever for the next 24 hours and required paracetamol infusion, which had to be given repeatedly in the first 24 hours. But after 24 hours, fever spikes started declining and the respiratory distress also settled down. And child gradually weaned off from oxygen in the next 24 hours. At 72 hours of admission, child was quite stable and afebrile with no respiratory distress and reasonable good appetite, but only symptom of cough persisted. And hence the child was discharged on oral oseltamivir and cough suppressant as and when required. So this case highlights about the rapid progression of disease and rapid recovery after the proper diagnosis and prompt antiviral therapy. So in this case, we had epidemiology, we have seasonality, and all telltale signs of influenza, which we confirmed with the multiplex PCR and instituted the treatment, and we got a very rewarding result. So this was second case, Prishit. He is a 10-year, 4-month male child. Is known case of seizure disorder on oral Valparin. Child had not had any seizure in the last 1 year. The child presented with persistent cough for 3 days and progressively increasing fever for last 3 days, 102 to 103, with weakness, body ache, heaviness of the chest. And just before landing into hospital, child had one episode of stiffness of the both upper limbs and upper rolling of the eyes, which was very transient. The child was admitted in emergency. His weight was 33 kg, height 137, temperature 101 degree Fahrenheit, pulse was 137 per minute, respiratory rate 38 per minute, and normal room air saturation with blood pressure of 120 by 70 and no respiratory distress, no retractions. Child was fully conscious and oriented with normal CNS signs and no abnormal movement at the time of presentation. Child's throat was grossly congested and chest had shown bilateral conducted sounds and significant rhonchi. CNS and other systemic examination were normal. So we proceeded with routine investigation. CBC hemoglobin was 12.5 with little lower leukocyte count. CRP was borderline. X-ray had shown prototype bilateral parahilar prominence. And with this, we sent a fluid panel which was suggestive of influenza B. So this is the X-ray of the child. It's a classical parahilar opacities, and rest of the lung fields are looking quite normal. There is a little bit of hyperinflation also because child had some obstructive, like kind of a wheezing also. So after admission, child was started on IV fluid, IV amoxiclav. So the child was already taking amoxiclav on oral basis, and we started levosalbutamol nebulization. Oral oseltamivir was added after the report, and child showed significant improvement after 24 hours. So a little bit of nausea and lethargy and cough persisted for few days, but no further seizures were noted during the hospital stay. Child was discharged on day 3 on oral oseltamivir and supportive treatment. So this case basically highlights the underlying disease which being complicated with influenza-like illness and precipitating, in this case, precipitating the seizure disorder, which was quite dormant till this time. So my third case is, she is Avadhi, 14-year-old female child. She had presented with fever for the last 6 days. Initially, fever was high grade for a couple of days. Then the fever decreased in intensity and there was quite gap also in between. So child has been traveling to Rajasthan, and so she was just taking SOS basis paracetamol and had not sought in medical opinion. There was increasing persistent cough. When the child landed to Surat, they straight away came to me with severe lethargy. Child was unable to stand and lot of dizziness. There was a family history of fever and cough in two of the family members at their native place. On admission, child was very dull looking, febrile 101. Child was quite dehydrated and blood pressure was 90 by 60 with respiratory rate of 32 per minute, SpO2 98%, heart rate 146. But there was no respiratory distress. Throat was congested, conjunctiva was also congested. Child had stomatitis and respiratory system examination showed bilateral fine crepitation in the lower zone. And rest of the systemic examination was not remarkable. The child was investigated to rule out any significant coexisting diseases as well as it was influenza season. So we proceeded for that also. Her CBC shown a hemoglobin of 14.2. There was a hemo concentration because child was quite dehydrated. The leukocyte count of 3,400 with neutrophil 45%, and platelet was also a little on the lower side. CRP was 10, and chest X-ray showed bilateral lower zone haziness. You find reticular kind of a pattern. And BioFire had shown influenza A, H1N1 positivity. So on the course of hospital admission, child was started immediately on IV rehydration, and IV ceftriaxone was initially started with nebulization with levosalbutamol. And once we got a BioFire report done, we added an oseltamivir. And after rehydration, child showed significant improvement in general condition. And within 36 hours of oseltamivir, child improved significantly with improvement in fever and respiratory signs. There was good appetite, no letharginess, child was active and agile, and hence the child was discharged after 3 days on oral medication with oral oseltamivir. So this case basically highlights that though the child presented on later, like maybe on 6th day of illness, and we were a little confused, but considering the seasonality, we tested and we started oseltamivir, and it had a wonderful response, and there was a dramatic improvement after starting oseltamivir with supportive treatment, of course. So this indicates that even in the later stages of influenza also, we can use oseltamivir with good effect. Dr. Ketan, please.
Yes. Thank you, Dr. Ravi. It's very nicely elaborated the real life case scenario. The first case highlight that early use of oseltamivir, early recovery. Second case, respiratory illness precipitating the seizure disorder, which child was already on that. And if you start oseltamivir, further complication can be avoided. And the third case, where the presentation was late, but the recovery was very fast. So a very nice elaboration of use of oseltamivir. Same way, these are few more cases. Any infant less than 2 weeks, history of fever, cough, cold, and there is a strong family history of cough, cold, and fever. One adult is admitted for respiratory infection. So this is likely to be highly contagious disease, and influenza is one of them. And 2 weeks old child is at risk infant. Definitely, oseltamivir is indicated here. A known case of nephrotic syndrome who is on steroid. He is an immunocompromised child. He is not vaccinated for pneumococcal and for influenza. If we get a respiratory symptomatology with myalgia, fever, cough, cold, or influenza-like illness symptoms, definitely he is a candidate for oseltamivir. The 9 years male child, known case of asthma, had a fever, cough, running nose, myalgia, family history of ARI. Again, this is likely to be epidemiology-wise influenza-like illness, and he's a real candidate for oseltamivir because flu itself exaggerates the asthma, and any child who has asthma getting flu disease, flu worsens up very fast. So here also oseltamivir is indicated. So it is said that oseltamivir is a wonderful drug for walking pneumonia, and for early onset severe symptoms, we have to prescribe oseltamivir. There are definitely a clinical trials mentioning about the benefit of empiric and early use of oseltamivir. This was one of the study where it has been found out that if you use oseltamivir, the results are really very good. 3,564 subjects were enrolled in this study, and the long-term complications, antibiotic use, hospitalization has been studied, and it has been found that antibiotic use has been reduced to 26.7%. Influenza-related long-term complications and recovery is much better if you start the oseltamivir early. The hospitalization rate can be reduced to 59% if you start oseltamivir earlier. Reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. Again, this was a retrospective study of 442 patients. Median time from symptom onset to oseltamivir starting was 5 days. Patients were divided into less than 2 days, 3 to 7 days, 8 to 14, and more than 14 days. Depending upon the starting of oseltamivir, it has been found that the probability of severe pneumonia significantly reduces if oseltamivir has been started earlier. But even if you start it late, the chances of getting severe pneumonia significantly reduces. Majority of the patient had shown significant improvement after 48 hours. Patient with a shorter time to oseltamivir administration were discharged earlier from the hospital. This graph shows that if you start the oseltamivir early, the discharge ratio in the early days is very, very high. The recommended duration for post-exposure prophylaxis is 10 days, and the recommended duration for community outbreak is up to 6 weeks. And for immunocompromised child, it is up to 12 weeks. The guideline recommendation are WHO recommends that empirical treatment is strongly recommended. Treatment should be started as soon as possible. Lab confirmation is not necessary. Negative lab report does not rule out H1N1 or influenza. In high-risk category who are exposed to a patient with influenza, presumptive treatment is recommended. Even the Indian government, Ministry of Health and Family Welfare Department do recommend that empirical therapy includes a neuraminidase inhibitor, that is oseltamivir. And a patient in the adult who has a community-acquired pneumonia, who is coming with influenza-like illness and has a pneumonia, dual therapy is recommended. So anti-influenza therapy with antibiotic in community-acquired pneumonia is recommended in epidemiological situation. And they do have a fast and early recovery. If possible, we try to get the microbiological diagnosis. But if microbiology is not possible because of financial constraint, then probably oseltamivir empirically in community-acquired pneumonia is also recommended. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empirical use is recommended in lower respiratory tract infections which has an influenza-like illness to reduce the complications, hospitalization, and overuse of antibiotic. It has been recommended by WHO, American Thoracic Society, and Indian government also. Thank you so much. Over to you, Dr. Jog sir.
Thank you, Dr. Ketan and Dr. Ravindra. You have elaborated greatly about the virus, about its clinical presentation, about the investigations, management, and that too with exemplary cases. Now, the point is that Dr. Ravindra already explained about some complications, and it is known that almost 25% of patients with influenza, they get secondarily infected either with Streptococcus pneumoniae or with Staphylococcus. So many times it so happens that a child who comes to our clinic with fever, cough, cold, we are in a puzzle, like as to whether to start antibiotics or whether we withhold the antibiotics. And in the influenza season, in case if the presentation is like influenza, whether to start oseltamivir or not to start. Some of our colleagues, they'll end up starting both antibiotics as well as oseltamivir. So, if Dr. Ketan, you can just guide our colleagues as to what are the clinical parameters on which they can base their decision of starting either the antibiotic or the antiviral, and at which stage of the presentation.
Thank you, sir. So basically, clinically, if you diagnose it as a viral respiratory illness, which has a running nose, which has a watering of the eyes, throat congestion, crepitation, myalgia, and a family history, this is most likely a viral illness. Antibiotic is not justified here. Any viral illness, if you have a category A, which is a walk-in patient with minimal symptomatology, antiviral is not recommended. Category B, where you have profuse watering of the eye, severe myalgia, prostration, difficulty in retaining the food or liquids. This is a category B. And if you have a family history or epidemiology favoring flu-like illness, here in category B, oseltamivir or flu medicines are recommended, antibiotic not recommended. Category C, who are hospitalized, who has influenza-like illness as well as a large consolidation with high count, respiratory compromise, their antibiotic and flu medications both are recommended. Thank you, sir. Over to you.
Thank you. So I think everyone is now clear that there are some categories of classifying influenza-like illnesses into A, B, and C. And category A doesn't need antivirals, neither requires any testing, while category B and C, you can think about them. In general, influenza is supposed to be an illness which is a systemic disease, wherein we have headache, we have muscle pain, and we also have severe weakness. Other viruses like rhinovirus and all, they come only with, runny nose and very mild fever. So influenza is supposed to be the father of all those influenza-like illnesses. However, certain situations are there where we need to find out and type the virus which is present in the throat. So Dr. Ravi, could you just quickly give us some information about the test, like the PCR test available for detection of the viruses, and how good they are in diagnosing influenza or other viruses, and what are the limitations of those tests?
Thank you, sir. So we have two kinds of tests practically in our city, like we do day to day. I would say both the tests are expensive and not easy for the pockets on many of the patients. So that is the one most important limitation of their utility. So first test we use is a non-typable kind of a PCR, which is also known as flu panel, which includes influenza A, influenza B, COVID-19, and RSV. So this is quite reliable test as such, and as we know that there are common clinical scenarios between all these illnesses, and we are quite often confused that which virus will be responsible for this kind of illness. So this is quite reliable and informative test. If once you have categorize the patient as ILI, this is one of the investigation which we can do, and it is relatively cheap. The second is a multiplex PCR or biofire test, which includes many viruses and lot of bacteria. Generally, in a very sick child, when we suspect either multiple etiologies or when we are not epidemiologically very sure about the respiratory illness, and this test is going to add to our treatment, then this is a very good test, and the positive predictive value is also very good. But certainly there are some contaminants which confuses us, so we have to take these all tests with a pinch of salt, and we have to analyze them and correlate with our clinical history and symptomatology.
Thank you. So I am sure that our listeners have a lot of information about the treatment aspect of this illness also, and we are all aware of the preventive measures which are related to the hand, like frequent hand washing and use of handkerchief and keeping a person at a hand's distance, and also avoiding hand touching. Many times these viruses are spread not only by droplets but also with the help of fomites, and that's why it is very important to follow all these rules related to the hasta. So I call these as hasta pancha sutri, the 5 sutras related to the hand, and that's why following that principle, I will also at the end just say namaste. Of course, virtually it is not possible to shake hands, but then at least I will shake, rather do only virtual namaste. Okay. So thank you, Dr. Ketan and Dr. Ravi. And you have elaborated that oseltamivir is a medication which gives a hefty kick to this drifty, shifty, and risky virus. Okay. So it's a hefty kick that the antiviral is giving. Thank you for the elaborate discussion, and I hand over the proceedings to Dr. Prashant. Yeah.
Sir, thank you for those lovely adjectives. These adjectives make the session very lively. And I'm
Thank you.
sure the doctors have benefited out of our interaction of the live cases. and many of the difficulties would have been solved. Thank you. Thanks, panelists, and thanks, Dr. Zhu. Thanks all the doctors who took time and attended these sessions. Thanks, Nagadevi. Thanks, Samriddhi. So we can sign off. We will join again.
Okay.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Dr. Ketan, you can go to the video icon
Ah.
Yeah.
and just press on that.
Yes.
Zoom setting
There
में